What I'm hoping to do today is to explain the principles, and as you have heard, I'm a hard-nosed scientist, and basically scientists have to depend on evidence, and evidence has to be obtained in rigorously performed studies where there's no bias, and you're quite sure that there's no error coming into your measurement, and you compare it with a control group and this sort of thing, which of course is very different from what you do in Feng Shui. But I'll first of all explain the principles. I'm going to describe how it works in practice for severe mental illness, because that's where we've developed it, which again quite the opposite of I think it's the opposite of your craft, because you're talking about most people, ordinary people, not people with severe mental illness. And of course, I'm not sure if you fully understand, but unfortunately, although we've made a lot of advances in the treatment of severe mental illness in the last 50 years, we've still got an awful lot to do. And we introduced this because we have so many patients with severe mental illness who are getting nowhere, and they're being treated with all sorts of unattractive forms of treatment that have minimal benefit and lots of adverse effects. And this really was introduced in that context. Where does it come from? The name nidus, Latin word nest, and that nest, we talked about nature earlier on. Nature, quite right. Nature tells you an awful lot about nidotherapy. A nest is a very good example of a natural object that accommodates odd shapes. No matter what shape is of the nest, it will fit inside. And Nidus UK is the registered charity that we developed, which is promoting this, not just in this country, but we have lots of efforts elsewhere. In fact, one might imagine the place which is really most keen on nidotherapy is Sweden. To go over there and give regular training sessions, because the Swedes, of course, love the environment. They've always been much more conscious of the environment than many other nations. There's a marvellous legal position in Sweden called allemansrätt, which means basically that anyone has the right to go anywhere. You can go to someone's garden, and you can actually, it's not private property, you can walk through it. I mean, obviously there are private places, but in fact, the whole country is everyone's right to go anywhere in the country. They have the idea of private woodlands, private fields, privately, all that is against the Swedish idea of things. So they're very interested in nidotherapy, and they've actually developed it more than we have in the UK. This is the definition, which again is a scientific type definition. Collaborative, very important. We aren't telling people what to do. It's got to be done with the person. It can't be done independently. It's systematic. We often take account of the environment in mental health, but we regard it as a sort of separate ancillary thing, not very important really, and we use it when necessary, but we don't actually think about it in a fundamental way. And we modify that after making the assessment, and the assessment has to be a joint one. I emphasize that over and over again, and then we change it in agreement. We try and work out a plan to change it, the nido pathway, if you want to call it the jargon, and that makes the person a happier place in society. And in some ways, the definition of nidotherapy really derives from Charles Darwin. Charles Darwin, his book, The Origin of Species, actually described his first edition described what's called the survival of the adapted. Unfortunately, he was forced to change the title in all other editions to the survival of the fittest, with the idea of people fighting for a space in the environment. Whereas in fact, survival of the adapted says, well, in fact, if you are adapted to your environment, specially adapted, there's no one fighting with you. You actually have a special place in that environment that no one else is fighting for, and then everyone can be accommodated. The 12 principles, I'm sorry, this is probably not much to read it all there, but we do emphasize that we've got to get in a trusting relationship with the patient, the individual concerned, and that's, we regard that as extremely important, because otherwise you become a controlling influence in the nidotherapy, and you in fact persuade someone to do what you want, but in fact that's not the right way to do it. It's got to be something that they are involved with and they actually own. So anything that goes wrong, you say, well, we started on this, you agreed with it, you were very keen on it, let's see what we can do to get around it. By owning it, you can make much more progress than if in fact it's imposed from outside, and more importantly, it's a more appropriate type of intervention. The other ones, all people have the capacity to improve their life in the place of right environment. These are all perhaps mom and apple pie things, but they're pretty important. Particularly those with severe mental illness, I'm sure many of you will realise, is that the options for environmental change with severe mental illness become less and less and less as you become more and more chronic, and you actually can finish up in a sort of locked environment, now not in a hospital, but a care home or something like that, where in fact everything about your activities is controlled from outside. Your autonomy is almost non-existent. And one of the big things we're trying to do in nidotherapy, and it's the thing which comes up over and over again, when people say what they want, they don't actually use the word because it's used in different contexts, but basically they want more autonomy, they want more ability to decide their own lives. These other ones I'm not going to go through in detail because of time, but you can see that they're all important, and people follow them 20%, they don't follow them 100%. One of the big worries in mental health nowadays, and it's unfortunately exaggerated by the media, which unfortunately the Murdoch press has actually done an awful lot of bad things for mental health, because they make out that most people with mental health are dangerous, risky, dangerous people who must keep away from. In fact, but it's a very small minority who are. And this thing about risk is that everyone's obsessed by risk nowadays. They can't do anything unless you have a proper risk assessment. I've been working in London for the last 25 years, and when I first came down, I was in central London in Paddington, and none of my colleagues would go out to the community to see patients because they said it's too dangerous. Complete nonsense. I've been working in the community in all sorts of ways. I've looked after homeless in central London, I've looked after Chinese people in Soho and various gangs around there. I've never been attacked. I think there's a lot of myth and nonsense about the risks of people with mental illness. This is unfortunately hard-nosed science. You may not see it all in the back, but basically it's saying that when you start off with a treatment, you have to find the right theory behind it, and you model it to see how it works. If I was being scientific, and please come contradict me if I'm wrong, I would say Feng Shui is still at these stages. Because I haven't seen what is now the hard science of it. You do an exploratory trial, and you say, all right, I'm going to do a study where I randomise half the people I go and see who are allocated at random to Feng Shui, and the other half have something else, standard old-fashioned environmental training, whatever it is, or doing something else, and then we compare the outcome. And then if that works, we then do a very big study, and we 500,000 people. And in the NHS, when you do this, and it's very positive, they will then introduce guidelines which make other parts of the NHS do it. I do a lot of work for the National Institute of Clinical Excellence, which is NICE, which is the organisation that evaluates treatments in various areas. And when in fact solid evidence that something works, they say this treatment ought to be introduced in all hospitals for this condition. So if we're doing this with Feng Shui, and Feng Shui is particularly important to a certain type of mental illness, and we did these trials, we got the part here, then in fact you could get the NICE guideline which said all hospitals should have Feng Shui for this particular condition. And therefore, if they didn't introduce that, they in fact would be fined or criticised or generally reprimanded. So this is the way we move forward on the scientific side. And in the case of nidotherapy, we're halfway here. We've done these, we haven't got it, but we haven't done a really big one yet, and so we can't get to long-term implementation. So that's the position with any form of treatment, which is a complex intervention. And I think Feng Shui is a complex intervention just in the same way that nidotherapy is. With any form of treatment, we have to select the people who ought to receive it, and that, in your case, obviously, the people themselves come along and ask for advice. they may not take the advice, and they may, but I suspect you wouldn't say, oh sorry, you're not suitable for treatment, you haven't got the right environmental issues. I'm not sure perhaps you would say that, discuss that in later on. But in the case of nidotherapy, we have to have a clear range of people who we regard as suitable. The form of treatment can be either to the person, it can be a group of people with the same condition, or it can be the staff who look after a group of patients. And then there are these four different components of treatment: environmental analysis, which is quite a big thing. We can make a lot of noise about psychoanalysis. Sigmund Freud made a great deal about psychoanalysis. It's affected the whole of the way we think. In fact, we don't actually do exactly, we ought to be doing the same thing with the environment. Environmental analysis is also a pretty complex thing. And then we create this pathway, we set the timetables for it, and then we modify and monitor it to see if it needs any changes. And we're not quite sure who, in fact, ought to be giving this treatment. People who give it, we think, ought to be trained, but we're not quite sure who the best people to give it are. The interesting thing that we found in our treatment is that most of the people who practice normal mental health activities are not great at giving nidotherapy. It's almost as though their training has actually focused their intervention on the individual rather than the environment. They keep on bringing the individual, treatment of the individual, treatment of symptoms, treatment of behaviour into the forefront of their thinking instead of looking at the environment. So that's an interesting point, and certainly in Sweden, most of the people who train very successfully are in fact support workers of various sorts who are not the low down in the hierarchy, but certainly extremely effective when it comes to this treatment. The important thing is, when we're seeing patients, is that, as this point here said, the first task is to judge whether it's the patient or the environment that needs to be the main priority. And of course, we have a whole range of problems of mental illness where, in fact, we do know that there are effective treatments, and there's no point in introducing nidotherapy there. Just to give you one example, in very severe depression, the person feels they're absolutely useless, they've spoiled everything in their lives, they've created a burden on everybody. So you can get someone who's extremely successful and got a very good job with a high salary, who feels that they've got to give everything up and go and live in Houghton, Scotland, because they just failed everybody. That could be an obvious environmental change when you're very depressed, when in fact you're better. That is completely different. So you don't actually give nidotherapy to people who suddenly change their behaviour and are obviously unwell and may need independent forms of treatment to get them back to where they were normally. So you treat patients only when they fail to respond to other treatments that we know are meant to be effective or allegedly effective, and they've been like that for a long time, or in fact they've got a condition which in fact doesn't have an obvious treatment. And we've used it a lot in intellectual disability, and we're using it more in autism now, which is another long-standing condition often associated with intellectual disability, where in fact the environment is very important, and in fact we are still floundering when it comes to treatment. Unfortunately, those who may deal with autism, I've been involved indirectly with it for many years, and it's remarkable how little we've advanced in the way of treatment. We've advanced enormously in the way of knowledge, but we've advanced very little in the way of treatment. So we ask whether the patient's got treatable pathology. That's our language. That's why the assessment of nidotherapy, we normally need someone who's got mental health training. And so, where it may slightly, for example, if you look at what I'm saying literally, you might actually see somebody who's got a significant mental illness, but not perhaps understand fully that they actually could respond to conventional treatment, and perhaps they shouldn't go straight into an environmental form of management immediately. The language we use in all forms of medicine now is evidence-based treatment. In other words, we don't give treatment unless we've got the evidence I spoke about earlier, which is organisations like NICE. If you've given those treatments and you've given them properly, and the person still hasn't got better, then okay, that person may be in your territory. Is a patient keen to have further therapy? If they are, then in fact, normally one would say, well, we're not sure if this is going to work or not, but we haven't got any good evidence for that. If you accept that and we'll try something else, will go ahead on that basis. In fact, most of the people we see, they're only too keen to stop the treatment they're having and don't want any more of it because they're so fed up with it, it hasn't worked and it's caused all sorts of problems. So those sorts of questions, that question is easily answered by the most of the people we see. And could environmental factors be a significant part of the problem? And almost always the answer to that is yes, because although some people at first find it difficult to accept that or regard other people as being responsible, they say, well, I can't do anything about it, I'm locked up here, I can't, I've got all my restrictions, no one will ever change things, so they've almost given up. But in fact, when you get your full environmental analysis, you can find all the things that they really want to get changed and might be suitable to create improvement. The environmental analysis looks at every single part of the environment in all its forms, and obviously you're very skilled at that in the immediate environment. We're looking at perhaps other elements which you do as well, but we look at them perhaps in a slightly different way. Involve both patient and therapist in equal measure. Even if the person we're talking to, and it certainly applies to many people with severe mental illness, seem to be talking nonsense, you listen to them very carefully because usually there's a germ of truth and importance in what appears to be nonsense, and that has to be brought into your management. It doesn't just involve the physical environment, it involves the social environment, people around about them, in their lives, neighbours and so on, and the personal environment. If they feel safe and settled, again, you're fully aware of this area as well. And the important thing which we have to emphasise, and this is where some of our nurses and other people who have been trained in mental health aren't greatest at it, there's no pressure to change the person. We don't treat the person, we don't treat the untreatable. To change the environment, not the person, and of course, there's no that much. People say, well, that overlap would explain it. These things work, a great person, that's how I say it, the person is more settled, so therefore, it does get better. Books around the that's quite interesting in itself. One of the big problems with Diane Powers, not very much, psychoanalysis, is that often translocks and counterparts, square pegs and square holes, hexagonal holes. If you look up the website, nidotherapy.com, you'll see a bit of education on nothing really called for patients in nidotherapy. There's also a BBC film. Certainly my colleagues in psychoanalysis like nidotherapy. Said you actually don't get involved in this. They know about nidotherapy when they're outside of the person or patient. And then find my email address. It also dissolves boundaries for people, and that I've said this many my colleagues who say that you should not allow boundaries. You should be a therapist and you should be a patient, and you should not have these boundaries. We've just been treating someone in nidotherapy for chronic schizophrenic. Unfortunately, chronic schizophrenics smoke an awful lot. When we first started seeing him, he was smoking 40 a day. A year after we saw him, he developed cancer of the lung, which is treatable. He stayed at our house 10 days ago, overnight, with his girlfriend because of all sorts of problems at his home. And he died 2 days ago, and I'm going to his funeral next week, which is going to be an eco-burial in a wood where we have got involved with our treatment, which support our principles of nidotherapy, and that this is a community woodland in the Midlands, and we'll be going to his funeral. Well, I mentioned that to my colleagues, and they said, boundaries, you should never have any. I mean, you're staying in your house, it's quite the wrong thing to do, you've developed that. This has actually fitted in perfectly with his treatment. And interestingly enough, when we first saw him, he said, I've got nothing to leave behind me. I've had a miserable life. The whole of his life is a computer that's been operating his brain. He said, nothing you do will make any difference because the computer decides it. This is one of the common symptoms in schizophrenia. And we've actually now recorded, this is agreement with a local radio station, an audio diary of the last 2 years, which is a pretty graphic 2 years. It involves getting cancer, it involves being beaten up twice, it involves breaking his jaw, and all that's going to be recorded. So he is going to have a memorial. We're going to have this recorded on a local radio station, and his family are very keen for that to go ahead. So that was his limited aim. That was his aim in nidotherapy, of doing everything to make that possible. And all the time we've been doing what psychotherapists say you should never do, is that you've broken boundaries between people. I regard that after 50 years in psychiatry almost as total nonsense. This is an important thing about true acceptance. One of the big problems we have in mental health is that we're, unfortunately, the only doctors who can take people's liberty away. And of course, in schizophrenia, we do it all the time. So it's really difficult to break down the boundaries and accept people as they are, and also to get them to trust you. And that's one of the reasons we try really hard, usually see people in their own homes, to get they're playing at home then, they understand and you get a much better feel of how they are. We fail to understand that managing the environment only is just as much a harbinger of change as treating a symptom. And that's something you probably understand very well, but unfortunately many of my colleagues don't. And we're emphasising again, you can effect change through the back door by carrying it out under the control of the individual, decided by the patient, not the therapist. And if in fact we construct a change, an environmental pathway, which is something we say, oh well, I've given up on this, this is surely the best way forward, it will trip up. So if you haven't got the person on board, then in fact it's not going to work. And this partnership may even extend to taking medication. I'm going to, I'll see the film clip at the end, the visitor film clip at the end. I'll explain about that now, although we're getting a bit short of time, I want to finish up very quickly, but it's one of our patients I saw 24 years ago, first of all. She had 17 admissions to hospital in 16 years, almost always about 6 months, almost every year. She had schizophrenia, and each time she came in, she was completely crazy, and she was kept in hospital. And then when she went out of hospital, she refused to take medication, even though that medication normally would keep her well, with lots of side effects. She wouldn't do that. After 5 visits to see her for the first time in 1990, we agreed that we wouldn't give her medication. And the important thing was when she got better, when she got ill, that she didn't expose herself to the community, because she would be seen as mad and brought into hospital. So she had to make her house, her flat, into a secure fortress where she didn't need to go out. She could pick up when she was going to get ill, and she just had to be walled up in there until she got better. You would have concentrated greatly on making sure that all the things in her flat were right. I didn't do that. That's why I've already done that. And in fact, that has worked, and in the last 24 years, she has had 1 admission to hospital for 7 days, and she's taken no medication. So that's a bit unusual, because in fact, when we found out when she's ill, she's actually ill for only about 2 weeks at the most. And most people with schizophrenia go on being ill. In her case, if she was stayed out of circulation for 2 weeks, she was all right. So that's a very good example of, in this case, taking medication. We actually help people, in her case, taking no medication. In other cases, we get people down to a very low level of medication by getting their environments much better. And because medication causes so many problems in this group, that's an important gain. One of the big problems that we find with our colleagues is that when we're recommending things, they say, you can't do that, that's not normal practice, you can't do that sort of thing. And when the patient wants it, they in fact say, oh, this is totally impossible, no, it couldn't possibly work. We have to act as a patient advocate and say, well, look, give this a chance, this is how we work things out, we've got systematic reasons for believing this is going to work, please give it a chance, and then we can often persuade the powers that be for things to go ahead on that basis, but we need to support the patient. They have very little power on their own, we've got to support them there. I've already mentioned about the dissolution of boundaries. We haven't had problems when people talk about saying, well, if you have boundaries, you get abnormal dependence, you get people phoning you up all the time, or you get people really unable to get better, needing all the time. We haven't come across any of those problems. Once you've got a clear relationship and you know it's a proper professional relationship, you don't have those difficulties. I've mentioned that already. I'm not going to. This is Avis, that's the one I can't show you. It's on our website, and you'll be able to. You can see all that later on. I'll show you the address of the website. The similarity to the nidotherapy is that Strong focus on the environment, recognition the environment creates many mental health problems, and a systematic approach to changing the environment. Still not quite sure how systematic Feng Shui is in changing the environment, but you can tell me. This is the main difference, is that we are part of evidence-based psychiatry. We compare effectiveness in a different sort of way. It's not prescriptive. We don't decide, we don't analyse the environment and decide what to do, which I think you do. We analyse the environment in conjunction with the patient, and the patient working with us decides what to do. And we also look at every aspect of the environment. I think you would say you do the same, but I think possibly we may do it a little bit more intensively. So environmental treatment has been developed with severe mental illness and burnout for the treatment options. Its principles apply to all mental health problems. We're not pretending it doesn't apply to others as well, but that's why I'm most experienced in that group. There's an overlap with Feng Shui, but it doesn't appear to be a great one. That's how I feel it is at the moment. So there's some books around in the room. This is a book I've written, which is £9, not very much. Fits these little blocks into square pegs into square holes, hexagonal eggs into hexagonal holes. And if you look up the website www.nidotherapy.com, you'll see Avis, who's a patient on the thing, which I think called 2 Patients in Nidotherapy. There's also a BBC film called The Madness of Dancing Daniel, which is a terrible title, but it's a 40-minute film about nidotherapy in practice with an impossible to treat patient. And that's my email address if you want to get in touch and know more. But there's a lot of information on the website.